for taking this up.
Yeah, thank you so much. Thanks, chairpersons and organizers, for giving us this opportunity to talk to all of you on the emerging risk of non-communicable diseases. We are very fortunate to have experts from different walks of life. They are all pediatricians, but also having the expertise in different areas of work related to NCDs. So I'm really grateful to the chairpersons and our expert speaker. Just to begin, a few things. This is our expert panel, which you can see. We are diversified people with bringing different kind of aspects. So we will have 4 topics today to discuss. One is rheumatic heart disease, asthma and chronic respiratory disease, sickle cell disease, and type 1 diabetes mellitus. Okay, these are the 4 marker conditions which are actually, we think, are a serious concern with respect to the burden and the children's suffering, so which we can address one by one. The remaining one, we are not undermining the cancers and mental health diseases and injuries. They are important, but we do have programs designed for them. For this one, at the moment, we don't have a structured programs in the country. That's why it calls for all of our attention. It's very common to notice 71% of the preventable adult deaths are linked to the risk factors that start in childhood or adolescent period. However, the screening in health and wellness centers for NCD starts once the person becomes 30 years. The question is, why do we wait for 30 years to watch the disease progressing? Can we intervene early? It's a question. Childhood NCDs are increasingly recognized as major contributors to premature mortality, disability, and reduced life expectancy. And our esteemed speakers today will talk about what is the longevity in these different conditions. Can we learn lessons from developed world? Can we learn lessons from developed states like Kerala and Tamil Nadu, which are actually leading the way in the work of NCDs? Okay, and to do this, we need to overcome some challenges. I summarize them as follows: access and affordability gaps. There's a many times they present very late, and there is acute complications in different conditions. There is a very weak supervisoryship or the chronic care systems. Many of these diseases require registry because they are chronic care, unlike in infectious diseases. So there is a lot of financial, geographical, and data-related gaps. We are not related. We don't have much country-level data, population-based data. Whatever data systems we have, they are quite strong on the facilities. So that's why sometimes the incidences look very high. So don't be, interpret this data as a community data. But in a developed world, there's a community level data to inform actions. So I was just trying to compare what's happening in the world. T1D life expectancy reduced by almost 12 years, 12 to 18 years in India. Dr. Zalak will throw more light on this. At the same time, you see global high economic countries, the people live up to 65 years, average life expectancy, type 1. Can you believe this? 65 years. That means they are living normal life. But at the same time, we see developing world struggling with economy. They live very small. The children, we lose them very quickly. Same thing, rheumatic heart diseases, you can see we have a lot of things to be done. Of course, Kerala, Tamil Nadu, there are not many cases. The professors are struggling to demonstrate cases. That's what I heard from Rahul today. Okay, that they don't have cases, rheumatic heart diseases, for a case presentation to the undergraduates now. Very good news. We would like to be in that position all over India. Sickle cell disease, there's a big plan, national sickle cell elimination program is there, centrally sponsored by union government. But the access is limited, and tribal districts, we have a lot of challenges. Asthma, we need a lot of things to be done to set our protocols in place, prevention of allergy. So basically, we have 60% of all adult deaths happening from NCD, and we have not discussed enough, and we don't have programs, which requires a lot of attention. And we need to talk about emerging risk. If you don't attend and address this now, the cost of inaction is very high. So we need to improve a lot of things: prevention, early treatment, diagnosis, all of them. For the clinicians, you know very well, we need these 5 things for treat any of these 5 NCDs. NCD. We need a treatment protocol, medication supply, task sharing in the team. Expert alone cannot manage everything. You need your facility, entire team to respond to the challenges. We need to keep patients in the center of all the treatment protocols, and we need information system to know what's happening to our disease load and survival chances. So this is a summary. Please don't mind otherwise, but I just want to say at the bottom level for the chronic care, you need a primary health care. In the middle, you need a pediatricians or the general pediatricians or the people who are having some experience managing these cases. You need a system at we call PEN, package of essential NCD services. Okay, and there is also PEN Plus. PEN Plus talks about managing the complications, like pediatric endocrinologist, pulmonologist. They manage everything. Okay, but doesn't mean that we need only expertise everywhere. No, we have a primary care, we have a level 1, level 2 care, and we have a level 3 care. Okay, this kind of a system addressing both public and private sector is what is required. So now, my last speech before I hand over to the experts, we need to listen to the young people. Okay, we want them to live normal life like other peers. So the participation and consultation with the children throughout the planning process is very important. They say nothing for us without us. My colleagues again throw more light on this. There's a lot of pediatric parent support groups in type 1 and other cases. So these groups are very strong. We need to nurture them, empower them, and I thank all the parents of this parent support group, because they become parents to the other cases, new cases. These parents of the people living with NCD, they give a lot of knowledge, experiences. We need to empower them. The picture, what are these pictures? The bottom picture is a World Health Summit where I had the opportunity to facilitate organizing a consultation. Half of the people sitting there are children. They demand what they need. They share their experiences. We cannot decide for them without consulting with them. And the top one is a World Health Assembly. This September, they will be making a resolution. World Health Assembly will make a resolution to prioritize NCDs in the pediatric NCD in the heart of NCD agenda. So when the global decisions are made, can we make something for our country? Okay. So I think I'll stop here, and I look at Dr. Rahul, who has done a lot of work. He's a nodal officer for child health in Kerala, to come to the podium and share your wisdom. What did you do to reduce the burden of the congenital heart diseases and rheumatic heart diseases in your state? The floor is yours, Rahul. Please come.
Good afternoon, everyone. First of all, thank you for the opportunity to come over to Gujarat and present on what we could do. So, I have been asked to focus on heart diseases. The point when I talk about heart diseases in children, there is a program, Hridyam for little. Am I audible? Okay. So there is a program in the state called Hridyam. Hridyam means related to heart. So this program is basically focusing on congenital heart diseases. I will explain to you the workflow of the program and how it has helped in addressing the infant mortality and in the survival of children with congenital heart disease, both critical and non-critical. And apart from that, as Narayan ji had mentioned about the rheumatic heart disease, the overall incidence of rheumatic heart disease in the state has come down due to the improvement in the overall living condition of people. As we all know, one of the major contributors is overcrowding. So there is a decline in population, there is an increase in the general standard of living, there is an improvement in education, there is an improvement in health facilities. So that is one area where government could actually step in. So through the Ardhra mission, the program, the primary health centers, starting from the primary health centers till the medical colleges though gets the support only in the RCH domain, but the primary health centers, a secondary and tertiary level of care, the entire system was actually strengthened, not just in infrastructure with the equipment side, the capacity building side. So all these actually led to early diagnosis, early initiation of antibiotic treatment, and now it is again expanding up to the level of an antibiotic stewardship program run across the state where proper and rational use of antibiotics are in place. So rheumatic heart disease, the contribution is not just from a health department, it is basically an overall improvement in the socio-demographic profile of the people across. Now coming to congenital heart disease, the Hridyam program, this is based on RBSK national program. So the model costing guideline which is used for running the program is based on RBSK national guidelines. So, but the particularity or the important step that has been taken at the state is how we integrated the public-private partnership into this RBSK scheme. So as we all know, this program was started in 2017 August. It was actually a part of the bigger plan of IMR reduction strategy, the action plan prepared. So this is not something done by any single person. There are multiple stakeholders involved. IEP was a key player in this program. UNICEF was a part of this program. There were NGOs like Children's Heartling Foundation involved. There were private hospitals which were directly involved in development of training modules, etc. So this is a teamwork which has actually worked in the state. So now it is into the eighth year of running this program. By this time, we have actually registered around 25,000 plus kids under the Hridyam program. So that doesn't mean that there are 25,000 plus or there is a huge incidence. The point is that all the minor conditions like PFOs and small ASDs will also get registered because there is a newborn screening program, there is a pulse oximetry screening program. So every children born in the state in the public sector are screened for pulse oximetry in the first 24 to 48 hours. And based on the result of this pulse oximetry screening, if they get failed, they get registered into this program. And this does not just happen in the public sector, even in private hospitals, when children are diagnosed with congenital heart disease, they get registered into this program. And apart from this, even the parent, the public can directly register into this. There is a web portal, they can directly register into the scheme. Post-registration, there is a verification process which is linked to the district early intervention centers, which is there in every district. So there are certain nodal persons, the DIC managers who does the listening activities and verification process, and the DIC pediatrician is the key medical person who is involved in this activity. Once the verification and the documents are uploaded into the portal, there is an empanelment scheme, there is an empanel list of pediatric cardiologists and cardiothoracic surgeons practicing, not just in public sector, but also in private sector. There are 8 centers currently enrolled in the state in this scheme, 3 or 4 centers yet to be added soon in this calendar year itself. So the panelists, the empanel doctors gets an opportunity to go through the documents and see the cases, and they can comment on their opinion. There is a categorization option. Categorization goes in 2 limbs. One is based on the severity of the condition and how acute the intervention is required. So based on that, there are 4 categories. I'm really sorry that I cannot demonstrate it. Through words, I have to express. There are 4 categories. The first category, again, is split into 6 subcategories, 1A to 1G. So A to G, it is basically intervention which is required in first day, second day, in 72 hours, then in 1 week, 1 month, 3 months, etc. And category 2 is basically for some planned interventions which are again subdivided into 2, and category 4 is a normal heart, and 3 is something that require medical management and follow-up. So that is how we categorize. And again, there is another, once we have 3 opinions from 3 experts in place, the state level administration can come with the final categorization. So this final categorization, most often the opinions would be similar, but at times if there is any confusion, what happens is that we go ahead with the decision that is made by the person who has seen the child. So there will be doctors in the list who have seen the child already. There will be doctors who have just seen the documents. So based on the final categorization, this gets open to all the empanel hospitals, public and private. The hospitals will then accordingly allocate a date of intervention for the child. So then the next step is that this is communicated. There is an IVR system. This is directly communicated in SMS mode to all levels of people, like from parent to the district level coordinator to the individual hospital. So based on the decision made by the parent, based on their consent, the child is allocated to that particular hospital which they have opted for, and the procedure is completed. And 1 year follow-up is ensured free of cost, and the entire payment is through the state machinery to the hospital. So that is how this process actually, this is the workflow of this thing. Not just the process flow, this has become flawless because of the data flow as well. So any program like we are talking about, all NCDs which are going to be discussed by other experts as well, the system as such, the issues lie in certain areas. One is we have multiple vertical programs We have health systems which are already in place, which need to be strengthened specifically so that we can build the capacity at all levels and engage multiple partners, not just in the public sector, but in the private sector as well. Another thing is the fragmented data system that is in place. We need to have a robust data monitoring mechanism, and based on which we can do a monitoring and evaluation. So these are some of the things. I think I'm out of time.
Yeah,
So thank you very much for this opportunity. I hope I could enlighten on some things. Thank you.
Thank you, Rahul. We request Zalak to make the presentation on type 1 diabetes and also add your experience on the diabetes in children, which is also type 2. We do notice. Over to you.
A short pediatric endocrinologist. Okay, so why are we discussing type 1 diabetes in children? Why are we discussing today? We know that type 1 diabetes has been increasing, and we also know that type 2 diabetes has been increasing because of the sedentary lifestyle and obesity we see in children. Type 1 diabetes is a lifelong condition to treat, cost of insulin, burden to the family, but we know that because it has to be managed lifelong, we improve the management, but the quality of life should also improve so that the years of survival are increased. As sir said, once the child is diagnosed with type 1 diabetes, the age comes down by 12 to 18 years of life expectancy. Average is around 65 years, but do you know the age of the current individual with type 1 diabetes in India? The longest living individual, he's 88 years right now. So why not give such a beautiful care, a good care to all our children living with type 1 diabetes so that future is bright and we can say that all the children, their life expectancy is too good. So what I will be discussing today is what is the burden, why it should be included in NCD programs, what are the challenges they face, how can we improve and strengthen the health system. So the burden of diabetes, as we discussed, it's increasing, and India is has one of the largest pediatric type 1 diabetes population. There is substantial and rising pediatric type 1 burden in India, but we are not sure of the true numbers at present. We have some registry, but we need a common registry where we can enter the numbers, what has been happening with the children with type 1 diabetes, their follow-up, so that we know that what is exactly the burden and how are they doing in their throughout their lifespan. Type 2 diabetes, we know, is a newer phenomenon in India and it's growing because of the sedentary lifestyle. We are not able to detect everyone, but we have children with pre-diabetes and even some getting detected with diabetes, but they are late. So why do we need to include diabetes in NCD programs? We know that in India, when we talk about NCD, they screen for diabetes, hypertension, stroke, and all that screening is that happens is after 30 years of age. But children should be included because when they are diagnosed late, they end up in ICUs having diabetic ketoacidosis and they end up having complications. All the clinics where there are NCD programs running up, even children should be included and they should have glucometers, and we should tell them how to detect early with the 3 T's. Thirst, toilet, thin. That should be remembered. Like thirsty, toilet means increased urination, and thin means losing weight. When there are 3 T's, they have to screen it. There should be access to insulin, strips, which should be free of cost, and there is lack of structured education also. Remember, a right education, proper education is key to a successful management of diabetes. So, after including in the NCD program for the early detection, which I'll be coming on to the later part, that how do we manage, how do we strengthen the health system, but what are the challenges the parents and children with type 1 diabetes face. Medical and healthcare challenges, late diagnosis, as we discussed, because we don't, as a pediatrician or a general practitioner, when we don't monitor the RBS, When they come to us, we don't identify the sign, they come really late. They don't have access to free insulins and monitoring like strips, CGMs. Financial burden is too much, not only for the monitoring and giving insulin, but also for the reports, consultation charges. Schools, we know there are no special rooms. They don't have medical facility. When the child has hypoglycemia or the child is sick, they don't have anything to manage. They don't have a special room or a refrigerator to put their insulin. And there are stigmas, obviously. There is bullying at school. That they have restriction. You cannot participate in sports events, not dance event because you have type 1 diabetes. So all these restrictions, some of them restrict admission to the school for children with type 1 diabetes. Psychosocial family impact, we know emotional stress, and in India we know ab shadi kaun karega meri beti se ya bete se. That is a big question when it comes to type 1 diabetes. Then future opportunities for a good job, earning, all that also holds a great burden to family. So how do we put children at the heart of NCD agenda? What can we do? Strengthen the data. Very important thing is create a registry where we enter the data, we know what is the burden, and so that we can get a good help. Strengthen the capacity to provide services of prevention, care and treatment. And policy advocacy. Community engagement is also important. Community awareness, those 3 T's. We should educate at the community level. It's important for parents. And multi-sectoral action for facilitating and enabling environmental health promotion, prevention and management. So what we can do? Registry, very important. How do we detect early? Awareness and training. ASHAs, PHCs, even school teachers, tell them if the child is passing urine frequently in the class, they have to get their sugars tested. So at basic level, community level, and general practitioners, pediatricians, we have to create that awareness. We can do CMEs and tell them, do not prescribe premix. Premix cannot be given in children. Give them a basal bolus regimen. And managing sick days, hypoglycemia management, that can be done at small villages where pediatricians practice. They don't have access to specialities, like pediatric endocrinologists are not available everywhere. So how can they manage? They can be in touch on over phone. Telemedicine is a good option for them. So that can be done with the specialist. Decay prevention campaign so that children don't end up in ICUs. And high-risk screening for their siblings. And how do we improve management? Yes, insulin, as we know, it's life-saving. It should be given free of cost and no premixed basal bolus therapy. Monitoring support, almost done. And type 1 diabetes clinic in major government hospitals, which include pediatrician, pediatric endocrinologist, diabetes educator, dietitian, psychologist, social worker, everybody. This has to be a team. So initially we can start up with some major cities and then telemedicine can be done through the district hospital or PHCs. School policies, we need to approach the school, manage, teachers have to manage sick days and hypoglycemia in school. And support groups through NGOs. We have Juvenile Diabetes Foundation in many cities. So there are support groups for the parents. There are many opportunities how we can improve the care for type 1 diabetes children. But I'm very thankful to UNICEF today to provide this opportunity, and UNICEF has always been very kind, and we have been in association to improve the care of type 1 diabetes in children in India. Thank you UNICEF and thank you organizers for this opportunity. Let's improve. Together we can create a world where every child with type 1 diabetes has opportunity to thrive and thrive well with a good quality of life. Thank you so much.
Thank you, Zalak, for your wonderful work and bringing your sense learning to all of us. Thank you. I request Rohit Agarwal for sharing his experience on managing chronic respiratory diseases in children.
Good afternoon all. I do not have slides, so I will not take much time. If my message reaches few of them, my purpose of coming here will be served. So non-communicable diseases and respiratory tract has a complex relation and which is not new to the pediatricians, cause the major chunk of our OPD practice in pediatrics, 30 to 40% comes as a respiratory illness, which is usually been labeled as URTI or LRTI, right? What am I talking here about is allergic rhinitis, allergic bronchitis, or asthma. So, what are the major culprits? Why this thing is increasing is the urbanization, globalization, the lot of construction, fuel emission by the vehicles. Even when you talk about the rural areas, so there will be today at the ground level, most of the energy consumption is through coal combustion. This all leads to a chronic inflammation which actually makes our children's immunity from tolerogenic to immunogenic. So this is where we need to discuss, we need to address. What are the major problems which are there are allergens. So if we discuss allergens, this may be divided into two categories, outdoor allergens or indoor allergens. Outdoors may be like pollens in which may be seasonal. Indoors can be house dust mites, there can be cockroach, the molds. These are usually perennial and have a longer impact. But this is on the older classification. The newer one is according to the particulate matter. So when we divide by particulate matter, it can be more than 10 to 20, which can be pollens, which are usually settled at the nasal level. So there you will get allergic rhinitis, or if in the eyes, allergic conjunctivitis. If they go from less than 10, 2 to 5, so there'll be house dust mites, there'll be spore molds, which may go into the bronchus and can create asthma. But less than 1 micro meter size are the viruses, and the viruses which may actually go and penetrate up to the alveolar level and even into the bloodstream and can cause chronic inflammation which may land up in the ICU also. So why are we talking about all these situations? Because these diseases are actually emerging, these are growing under our eyes, and there is a need of the hour to address them, to talk about it, to discuss, make protocols, and to overcome them. So how we are doing it is at the primary level with proper history taking, with proper examination, making proper treatment with inhalers. At the secondary level, by doing the proper referrals to the pediatric pulmonologist on time, and in the tertiary level at IAP National Respiratory Chapter is making asthma training modules since last 5 years at various levels, which is already been conducted. Even GINA is giving updations every year in GINA guidelines. There is not yet at ground zero level at PHCs any SOPs or protocols from the UNICEF. So I will make a urge to make something which is available, which can be done at very ground level for the children of India for their future. Thank you.
Thank you so much. You saved some time for us, so special thanks. Yeah, so now we have impact player, Vaibhav. So time is yours to talk about sickle cell disease and hemoglobinopathies in children.
Good afternoon. Thank you, Team ADOLESCON and UNICEF for creating this opportunity. So the point I am discussing about is today sickle cell disease. It is more important. Why? Because if you see, it is quite widespread disease, and it is the one of the most preventable cause in the spectrum of the non-communicable disease. If we go, it is very preventive counseling and antenatal diagnosis. We can significantly reduce the burden of the sickle cell disease in the community. So where do we are standing right now? So still in 2025, this was the little bit older data, but still new cases are getting added every year. And if you see the worldwide data, almost 50% of the patient die before the age of 5 years worldwide. And in India, 42,000 cases are added every yearly. And out of them, 20% even don't reach to the age of the 5 years. And more than 50% doesn't survive beyond the 40 years. And this is the very high belt, which shows the spectrum of the disease is very high amongst the Gujarat, Maharashtra, MP. These are the belt which we are looking for. So what are the challenges right now we are facing? So the diagnosis is quite delayed. We don't have the excessive facility of the newborn screening everywhere. So it is very much missed, and the patient, when comes in the crisis, we recognize that, oh, it is sickle cell disease. And that leads to the early childhood mortality. Plus, the belt, which is having a very high carrier rate, they are not aware of the severity of the problem. And that limited awareness is also costing a life. And the institutes are significantly understaffed, what we can say. And the training programs are not even that much directed towards the holistic management of the sickle cell. So considering that the government of India came with the plan of sickle cell anemia elimination by 2047, it is based on the three pillars. First of all, we should raise the awareness to that level so that no child with sickle cell disease is born, and genetic and antenatal counseling should play a primary role. But still, if it is not possible, at least we should strengthen our screening strategies so that earliest possible way we can diagnose the sickle cell disease and prevent the maximum number of the complication. And if that is also not the case, at least we should provide the holistic management of the sickle cell disease to all our kids. So it is their birthright to deserve that much care in the sickle cell disease. So the prongs of this strategy is on three parts. First is the universal screening. So emphasis is mainly on the screening, which will be among the targeted group screening. Younger population, antenatal mothers, and the newborn screening should be happening. On the parallel front, there should be the counseling awareness at the household level, at the community level. For this, we can involve the ASHAs and primary healthcare centers and all multipurpose health workers in that part. School level education program should be strengthened enough with the crisis sickle cell detailed involvement. And most important is the healthcare level. RBSK and all that program related healthcare staff should be aware about the early recognition of the symptoms and early referral. And parallelly, we should have the SOPs for the holistic managements. So screening protocol, now we do have a point of care testing for the sickle cell disease. It's like a rapid test which is easily available. So the current policy is they are screening all the high risk population with the rapid test kit, and whomsoever is positive for the same, they are confirming it with the HPLC. So that should be the point taken care, that point of care is not 100% confirmed. So it has to be cross-checked with the HPLC amongst antenatal as well as the newborn level. And wherever antenatal mothers are found the carrier, the next step should be to screen the partner is a mandatory thing. So this is the success rate of the newborn screening program. Left side is the Maharashtra data. If you see the frequency of the carrier, it is almost 3 to 4% carrier rate is observed on the newborn screening. On the right, it is the Gujarat's our own data from 2014 to 19. Even that shows almost 3.5% prevalence of the sickle cell disease. It is a good that majority of our kids have some co-harboring mutation, so the severity is less compared to the Southern Africas and remote African villages. But still, the carrier rate and the incidence is quite high to be taken care seriously. And if you see the antenatal program, where they screen the antenatal mother and then they screen the father, and then they have find out the targeted couples, almost 39% couples were targeted. And out of them, if you provide, majority of them has undergone the MTP. So yes, it is possible at the ground level. This is the treatment protocol. I'm not going much into the detail, but two main aspects: prevention with the maintenance of the hydration. We have to counsel repeatedly for the hydration, and the optimal use of the hydroxyurea should be the thing. This should be the level, at the PHC level, they should recognize the crisis in the early stage and they should refer to the higher level, and all the tertiary centers should be well equipped with the specialist and the proper genetic counseling. For the way forward, we have involved multiple agencies working in the healthcare. That has been done, but still our healthcare infrastructure has to be strengthened, especially all the medical colleges, and we should train more for the interventions. So yes, this is possible. And as a hematologist, I will say this is not only for the sickle cell disease, but for all the hemoglobinopathies possible over there. We should come together. We should strengthen our care to provide a better care. Thank you.
Thank you, Vaibhav.